All right, let's jump right into it. Today, we're unpacking the absolute bedrock of hospital care, inpatient admission documentation. We're talking about that crucial window where we translate clinical intent into compliant coding from the literal second a patient walks through the doors. Look, whether you're a clinician, a medical coder, or a clinical documentation integrity specialist, nailing this workflow isn't just nice to have, it is absolutely paramount.
So here's our roadmap for this explainer. We'll start with the Inpatient Admission Foundation. Check out the architecture of admission orders and then look at managing perioperative orders. After that, we'll weigh CPOE benefits and barriers, dig into those 2026 CDI query compliance standards, and finally, wrap up with validating clinical documentation. Let's get to it.
Section 1. The Inpatient Admission Foundation. The true front lines of patient admission.
Right at the very start of the patient journey, we have to establish a baseline. And there's a huge difference in depth between a medical and a surgical history and physical when a patient is admitted. Think about it. A medical admission H&P, usually run by a hospitalist, has to be incredibly comprehensive. It needs a massive systemic overview because you're managing complex, acute issues like sepsis or pneumonia. But a surgical H&P, that's a totally different beast. It is hyper-focused on surgical clearance, establishing that preoperative baseline functioning and zeroing in on the operative site. In fact, a lot of times this surgical H&P is done up to 30 days beforehand in an outpatient clinic. So upon admission, the provider really just needs to review it and document any interim changes.
Now you know as well as I do that a dictated H&P can take hours to actually populate in the electronic medical record. So what do we do in the meantime? That's exactly where the admit note comes in. While you're waiting for the whole comprehensive H&P to process, this brief narrative summary acts as a crucial, immediate stopgap. It lives permanently in the record, broadcasting the immediate treatment plan and presumptive diagnosis to the rest of the care team. That way, they can start treating the patient right then and there without waiting around for a full dictation to clear.
Moving to Section 2, Architecture of Admission Orders, structuring the actual plan of care.
Okay, so the H&P and admit notes are done. Now we have to build the actual architecture of the care plan, the admission orders. And honestly, the absolute best way to prevent a deadly omission here is by using a structured mnemonic. AD-CIVA Dimples is a total lifesaver. It guarantees you cover the whole shebang. You literally just walk down the list. Admit, detailing the physician and unit. Then diagnosis, condition, and activity level. You explicitly order the vital signs frequency, list those allergies, and establish a diet. Then you knock out interventions, medications, both new and chronic, procedures, and labs. You finish it off with special instructions, which are those super important conditional orders like, notify the physician if systolic blood pressure hits 150. Stick to a framework like this and nothing falls through the cracks.
Section 3. Managing perioperative orders. Navigating the surgical timeline.
So, for surgical admissions, things get a bit more complicated. A patient's status can change wildly during surgery, right? We have Phase 1, which is all your preoperative preparation and clearance orders. Then Phase 2 kicks in with standard protocols for the PACU while the patient wakes up. But Phase 3 is where it really gets interesting. Once that patient wakes up and stabilizes, they are essentially readmitted. This means a completely new set of post-operative orders. Those pre-op orders, they're totally voided. You have to sit down and write a brand new AD-CIVA Dimple set that is tailor-made for their new post-surgical reality.
Section 4, CPOE, Benefits and Barriers. The digitization of order entry.
So, putting all these complex orders into action brings us face-to-face with CPOE, or Computerized Physician Order Entry Systems. Look, we all love that the days of deciphering chicken scratch handwriting on a paper chart are gone, but digitization is definitely a double-edged sword. On one hand, CPOE is a game-changer. It basically eliminates medication legibility errors, gives us automated safety alerts through clinical decision support systems, and provides immediate remote access. That's huge. But we can't ignore the massive barriers. Beyond the crazy high implementation and training costs, CPOE introduces some really dangerous new risks. Think about drop-down medication selection errors. If two drugs have similar names, a simple slip of the mouse can cause a massive clinical error.
And that leads us to a huge challenge. There's a brilliant quote from the source material that highlights a very real crisis we call alert fatigue. It happens all the time. The system bombards a provider with constant, redundant, low-priority warnings. And what happens? We're human. We become completely desensitized. Providers start blindly clicking accept just to survive their workflow, which opens the door to accidentally dismissing a truly critical, life-saving alert. It's a stark reminder that digital tools are literally only as safe as the human workflows operating them.
All right, Section 5, CDI Query Compliance Standards. This is our clinical documentation safety net.
Once everything is actually in the system, our clinical documentation integrity specialists step in to validate it. Now, if the documentation is ambiguous, a CDI professional issues a query. But let me be crystal clear here. This isn't just shooting off a casual email to a doc. Under the strict 2026 AHIMA and ACDIS standards, a compliant query is a highly regulated communication tool. It has to be explicitly non-leading. It is never, ever about nudging a physician toward a higher-paying code. No way. It is strictly an unbiased tool to seek clinical truth, relying entirely on the evidence already in the chart, and it must completely allow the provider to use their own independent clinical judgment.
So what does that actually look like in practice? Well, the 2026 rules lay it out perfectly. First, you have to provide direct, sourced clinical indicators, like specific lab values, without throwing in any of your own subjective diagnostic assumptions. Second, you can't use formatting tricks, no bolding or highlighting to secretly point the provider toward the answer you want. Third, the yes-no query format is super restricted. You can only use it to establish if a condition was present on admission, to clarify cause and effect, or to confirm a diagnosis that's already in the chart. You absolutely cannot use a yes-no query to introduce a brand new diagnosis out of thin air. And finally, every single yes-no query has to include an unable to determine option because sometimes clinical uncertainty is just the reality.
Section 6. Validating clinical documentation. Reviewing the chart accurately.
Now let's tackle a really tricky area. What happens when a patient comes in with a massive electronic footprint of prior visits? How exactly should we handle information from a patient's past encounters when we're trying to clarify today's admission? Well, our query guidelines have a very strict playbook for how this historical data should be utilized. The guidelines lay down the law here. Data mining without a current clinical trigger is strictly prohibited. You can't just go digging through a chart from 5 years ago, find a random chronic condition, and ask the doctor to add it to today's note just to boost the coding complexity. Actually, scratch that. It's not just frowned upon, it is completely inappropriate. Now, if there is a current clinical trigger on this visit, like today's labs show abnormal kidney function, then yes, absolutely look back to establish a baseline. But the focus has to remain 100% locked on what is clinically relevant to the patient's acute presentation today. And that brings us to the ultimate golden rule. No matter how many clinical indicators a CDI specialist uncovers, and no matter how beautiful those CPOE admission orders look in the system, the final call doesn't belong to the software or the CDI team. The power and the profound responsibility of the final diagnosis rests entirely on the independent clinical judgment of the treating provider. Period. They alone decide if the clinical threshold for a diagnosis has actually been met.
So I want to leave you with a question to really chew on regarding your own facility. From the initial medical H&P to those AD CAVA DIMPLES orders, right on through to a compliant 2026 CDI query. Does your hospital's workflow truly bridge the gap between initial clinical intent and final coding accuracy? It is one continuous chain, and a weak link anywhere impacts both patient care and data integrity. Thanks for hanging out for this explainer, and please like, share, subscribe to Decode Healthcare with Harshal.